Hey everybody, it's Dr. Wood, and today we're going to talk about Chapter 15, or Analgesics and Antipyretics. So to start out with, what is pain? Basically, pain is a very subjective sort of experience, meaning it's different for everybody, right? One of the most common ways we have to measure pain is just to simply ask a patient on a scale of 1 to 10, what's your pain like right now? With 1 being no pain and 10 being the worst pain you can possibly imagine. You're going to find it's really difficult to actually get a good handle on that because someone could say, oh, their pain's an 8 out of 10. And that could be very different than someone else's pain that's an 8 out of 10. So again, this is a terribly tricky subject. We also know that we're in the midst of a opioid crisis here in the U.S., where we have way too many patients who are abusing opioids. They're potentially physically dependent or addicted to that. And we'll talk about some of those issues here in just a few moments. Basically, though, what is pain perception? That's just the awareness of a painful stimuli, right? Not everyone has the same amount of pain perception. So, for instance, if you had a patient with diabetes, they can develop what they call a neuropathy, a diabetic neuropathy. And that's actually something where they may not be able to feel pain, say, for instance, in their feet, which is a common reason why they may actually have, say, for instance, they step on a nail and they don't even realize it because they don't even have that pain perception. And then they get a wound infection, right? There's what we call pain threshold, where this is actually being able to acknowledge a stimulus is painful or not. Again, some people have different thresholds for pain. And then certainly pain tolerance is another issue as well, where the ability to tolerate pain is very different from patient to patient. Some people have very good pain tolerances. Some patients have very poor pain tolerances depending on the situation. Now, naturally, our body will release things like endorphins, and that actually will block painful signals both in the spinal cord and in the brain to try to mitigate some of those painful stimuli that are making up. And so by blocking that, you basically block the perception and hopefully increase that tolerance to pain that it's occurring. So what are some responses that patients may express when they are having pain? Well, obviously they can have things like contorted facial expressions. They can just look like they're in pain. They may change in posture. They may be guarding certain things. They may be holding a limb or something like that. Frequently, though, we may look at things like vital signs, where we'll look to see, like, is their blood pressure elevated? Is their heart rate elevated? That could be a sign that they're in pain. However, keep in mind that as patients get more from acute pain, meaning it's an acute sort of issue, like, say, I broke a bone recently, or versus a chronic issue, like chronic back pain or chronic fibromyalgia or things like that, they may lose a lot of this just because they're so used to the pain that it becomes more of an issue where it's more difficult to tell because subjectively they just look like they're really doing okay, even though they may be experiencing quite a bit of pain. Some other things you frequently see with this include things like restlessness, lethargy, and fatigue. And a lot of that has to do with the fact that if you're in pain, it's really difficult to get a good night's sleep. And so this is where you see a lot of like missing time from work because they're so tired they can't even get out of bed to make it to work, or they're in so much pain. So there's a lot of issues with chronic pain, whereas you're seeing a lot of quality of life issues being a problem. Also just issues in terms of lost time at work and societal impact. So this is a huge issue, and I'm not going to be able to touch all of it here in this topic, but at least kind of get you introduced to the issues. So some definitions here. When we say analgesic, that just means something that relieves pain, right? If I say antipyretic, that means something that's going to be used to reduce fever. And then when I say anti-inflammatory, that means it's actually working to reduce inflammation at the site of injury. And you're going to see that in some cases, medications may provide 1, 2, or all 3 of these roles here. So as an example, aspirin can actually accomplish all 3 of these. It provides pain relief, it can help reduce fever if a patient is ill with an infection, and can actually reduce inflammation. Some agents only do one or the other. Like, so for instance, like an opioid analgesic, like morphine, only will work as an analgesic and reduce pain. It has nothing to do with fever, won't do anything for inflammation. But you'll see by combining different medications together, you get synergy, and you get better use out of, you can get more utility out of using 2 together than you would with either one of them by themselves. So types of analgesics we'll talk about. Opioids are going to be a big topic here just because they're used very frequently, both in the inpatient setting and during surgery and all kinds of things like that, and also on the outpatient for more chronic use. And then we'll talk about non-opioids as well, basically meaning they contain no opium, they don't contain any products that activate opioid receptors, okay? We say co-analgesia, that means we're basically using 2 medications for synergistic effect, as I mentioned. And if I say an adjuvant, that means something that will work to increase or hasten the effect of the principal medication. We'll talk about a few examples of that later on. So talking about the analgesic ladder, this basically means that you can kind of, depending on the amount of pain the patient is experiencing, can kind of go with treating pain based on how severe it's presenting. So there's kind of mild pain, moderate pain, and severe pain is usually the most common ways you'll break it out. And so mild pain may be like, I have a mild headache, I stub my toe, something like that. Typically you're going to use pretty kind of wimpy drugs, so to speak. Things like acetaminophen, which is Tylenol, things like aspirin, or the non-steroidal anti-inflammatory drugs, otherwise known as the NSAIDs. Most of you probably heard of NSAIDs before, things like ibuprofen and naproxen. These are kind of going to provide the least amount of analgesia. However, they do provide some additional benefits. So for instance, aspirin and the NSAIDs are both anti-inflammatory. So if you have something like where you broke a bone or you strained a limb or a joint, a muscle, something like that, anti-inflammatory drugs work really well to reduce some of the pain associated with that injury, right? Versus opioids, they just don't do that. Tylenol does not do that. But these are good ones to start out with if a patient's in mild pain. For more moderate pain, this is where you can bump it up. Now we start to think about things like oral opioids, things like codeine, hydrocodone, things like that. Then for more severe pain, so this is like if you broke a bone and it's sticking out of the limb or sticking out of the skin, things like morphine, hydromorphone, this is where you're going to get better use out of some IV or parenteral opioids. Now, again, you don't always have to start at the bottom of the ladder here and work your way up. And in fact, if you had someone who's coming in with a broken bone that was displaced and you said, here, try some Tylenol for this, they're going to be very upset with you, right? Because you want to start off with something that's appropriate for the level of pain the patient's experiencing. So for really severe pain, you kind of start off with something like a morphine, and then you work your way backwards depending on the case. But if they come in with only mild pain, Tylenol is probably fine in those cases there. So looking at the different opioids we have available to us, some of these you probably heard of before, some of these you might not have, but these are common ones you're going to see used pretty frequently in the medical field. So we have things like morphine, hydrocodone, oxycodone, and codeine. These are going to be oral agents that are used. Probably the most common ones you're going to run into in terms of oral opioids being prescribed for outpatient use includes things like Lortab or Norco. This is basically a combination of hydrocodone and acetaminophen. And then you have oxycodone, either by itself as roxicodone or with acetaminophen called Percocet. The other big brand name you'll see for this is going to be Oxycontin. That's actually a long-acting form of oxycodone and lasts about 12 hours throughout the day. Then codeine is another common one you'll see used orally as well, usually in combination with Tylenol, and that's called Tylenol number 3. Parenterally speaking, we have several different options here, and these are going to be used more on the in-hospital side. This is going to be used in the surgical setting, things like that. Certainly not heroin. Heroin's actually not going to be something you use, but I only mention it here because this is a big problem we're seeing, especially here in Florida. We're seeing a lot more patients who are kind of switching from prescription opioids due to addiction. They're using more heroin now, and that's becoming a big problem in terms of the heroin the opioid epidemic here. But common ones you'll see in the hospital include things like hydromorphone or Dilaudid. You see fentanyl or just Sublamaze, and then morphine has IV forms as well. Duromorph is a common brand name for that. So what are the side effects you're most likely to see with opioids? Mainly it's going to be drowsiness and sedation, right? So you're going to see that it can cause some degree of sleepiness for your patients, which may be good if they're in pain. Also, some patients may get a lot of nausea and vomiting with this. They may get a little dizzy. But with chronic use, this is a really big problem we like to make mention of, is that constipation is going to be an issue. So again, frequently what we'll do is we'll recommend giving laxatives along with the opioids in order to prevent the constipation from occurring. Because again, imagine if you're treating someone for chronic pain, and all of a sudden you're giving them something like an opioid to help deal with that pain. They feel better from that standpoint, but now all of a sudden they're not having any bowel movements, and now their stomach's starting to cramp up, and now that's their new pain, right? And giving more opioids for abdominal pain due to constipation is not going to fix it. It's just going to make the constipation worse. So this is where we frequently give laxatives to make sure they're having consistent bowel movements and preventing that complication from occurring. Something to be cautious of when using opioids is the fact that it can cause respiratory depression. Basically, it blunts the brain's desire to breathe, essentially, and will cause shallow respirations, can cause some people to stop breathing altogether, right? And so this can be really dangerous when they're out of a hospital setting there. And so frequently we'll actually give what we call naloxone or Narcan to reverse this. And so basically, the drug will come in and will basically kick off the opioid from its opioid receptor and cause the patient to wake up near instantaneously. And so it's very dramatic to watch if you ever get the opportunity to, but it almost, especially for patients who are chronically on opioids and that are very physically dependent on them, if you give naloxone all of a sudden because they've stopped breathing, while that is appropriate, you can also put them into what we call withdrawal, which is very uncomfortable for them, and they very frequently wake up very upset and usually vomiting, and it kind of looks like The Exorcist a little bit. So those are things to consider with that. This is the reversal agent. It's good to know for purposes of anyone who is prescribed an opioid. They should know what the rescue medication is going to be for that. Also be careful if they have liver or kidney impairment, because they may not be able to clear the opioids effectively, and that can lead to more issues of respiratory depression and CNS depression. And as I mentioned, constipation is often going to be the most common side effect you're going to see with that. Other things, including that actually the cough reflex is suppressed, and we used to use opioids more commonly to actually treat cough, but it is important to know that maybe if they have, say, a pneumonia or something, maybe they can't cough up that purulent sputum, that can actually prolong their infection. And then the biggest thing to be cognizant of is the risk for physical dependence and addiction. Now, I'll camp out on this for a few seconds here, but basically these are two different things, right? Physical dependence just means your body gets used to having that drug around, and then when that drug is not around, you can induce what we call withdrawal, right? So physical dependence is a normal thing. You expect that to happen with opioids. If you're on an opioid for a long period of time, namely weeks to months to years, you're going to develop physical dependence. That doesn't mean you're addicted to the medication. It does mean, though, that if you have, say, if you quit the drug cold turkey, you're going to have withdrawal effects, and the patient's going to be pretty miserable, okay? Addiction is a whole nother ball of wax, where basically the patients are continuing to use the opioids despite the negative consequences thereof. So if you have someone who is maybe selling off their medications in order to get money to get opioids, that's considered to be addiction, right? If you have someone who is switching, say, from oral to IV, self-administered IV opioids in order to get a better high or euphoria from the drug, that is considered addiction. And so again, not everyone who is on opioids will become addicted. It just depends on a lot of factors like their social setting. It depends on their genetics. There's a lot of issues here. So again, keep in mind these are different. However, physical dependence can sometimes lead to addiction in some patients. So non-opioid analgesics, though, are going to be better for controlling more mild to moderate pain, and you're going to find that these have the greatest action more on the peripheral nervous system, depending on the drug we're talking about. The benefits of using these is they provide no physical dependence or tolerance, and usually their side effect profile is much better than what you would see with the opioids, right? Again, no change in mental status, no change in function. If I was giving a patient something like an NSAID, like ibuprofen, I have no problem with them going off and driving. If I give them an opioid like morphine, they are definitely going to be impaired, and they should not get behind the wheel of a car. So that is kind of the two big differences between the opioids and non-opioid analgesics. So the common ones you're going to run into, and most of these are available over the counter. So for instance, you have aspirin, you have acetaminophen, and then you have your NSAIDs. Something to note here is that aspirin and the NSAIDs are both anti-inflammatory, and they're antipyretic along with being an analgesic. Note that acetaminophen is an it's just an antipyretic and analgesic. This does not do anything for inflammation, okay? This is why you can actually use two of these together. Very frequently, patients will get a combination of acetaminophen and ibuprofen because they work differently together, and thus they provide better synergy. So there's one thing to note there. If you ever see someone getting acetaminophen and ibuprofen, that's totally appropriate in a lot of cases, okay? So some things to note in terms of patient education for patients receiving analgesics is that it's good to note that if a patient becomes allergic to one medication, it's important to know that they may be allergic to other medications in that class. So for instance, if someone's allergic to ibuprofen, they may have a cross-reactivity and cannot receive naproxen, for example, right? So that's one thing to know. And if patients are self-treating their pain, so they're getting these medications over the counter, it's really important they contact their providers if pain is still persistent, even after a few days or weeks, because there could be something more serious going on. They may need to get further evaluated for. If they are having stomach discomfort with taking the medications, have them take it with meals. That can oftentimes help with this. And then be aware of patients who analgesics may be contraindicated for. So for example, like you don't want to give something like ibuprofen or naproxen to a patient with kidney disease because it can actually decrease their kidney function acutely. Or you may want to avoid giving acetaminophen for patients with liver disease because it can actually cause liver toxicity potentially, okay? Typically want to avoid giving pregnant or breastfeeding patients these drugs unless they've been told that's okay by their OB/GYN provider. And then another big thing to note here is that you never want to give aspirin to children with a viral infection. So if they've had the chicken pox or they have influenza, never give them aspirin because it puts them at risk for something called Ray's syndrome, which can be fatal. Okay. Again, this is very specific to aspirin. They can definitely receive ibuprofen, naproxen, no problem. Now, other things to note is that it should stop things like aspirin 5 days before surgery. This is because aspirin can have some bleeding effects because it affects platelets. So by stopping it early, it allowed them platelets to kind of get back to normal. So that way they can have surgery without increased risk for bleeding. It's important to not take aspirin if it has a strong vinegar odor because aspirin can actually break down in the bottle over time. And so if it has that smell, it means the drug's not active anymore. And then it's really important, especially if patients are treating themselves at home, to not exceed the recommended daily doses, especially with acetaminophen. Usually acetaminophen is limited to 4 grams per day because if you start to go above that, you can see things like liver toxicity with Tylenol, you can see kidney toxicity, things like that. So just be aware not to exceed the normal daily doses that are recommended on the bottles. And again, note that acetaminophen only is an antipyretic or analgesic, does not provide anti-inflammatory activity. Be careful with this Tylenol or acetaminophen because if you combine it with alcohol, that can increase your risk for liver damage. So be aware of that. And then be aware that aspirin and ibuprofen should not be taken together. This is because the two drugs work the same way, they have the same mechanism, and thus they can actually increase the risk for toxicity. Now, Tylenol and aspirin, that's an okay combination. Ibuprofen and Tylenol, that's an okay combination too. Just don't combine aspirin plus ibuprofen, or naproxen would be on this list as well, okay? Because they both work the same way, only increasing your toxicity risk. Now, frequently we'll go ahead and combine analgesics to get better effectiveness, and this is good for more moderate and severe pain. That's why we frequently will see opioids mixed with non-opioids. So, for instance, hydrocodone and acetaminophen is Lortab or Norco. It's one of the most prescribed drugs in the U.S. Just note that anything ending in CET contains acetaminophen, meaning like Percocet or Fioricet. Anything ending in the DAN usually means it contains aspirin, like Percodan. Just you want to know that, so if you see a patient who's taking that and it's listed as a brand name, you know exactly what they're getting. So that way you don't give them any additional Tylenol, you don't give them any extra aspirin, because that could lead to toxicity issues. There's other medications we can also give. I'm not going to get into depth here on these because we might talk about them in some other chapters here. But frequently, if patients have things like neuropathic pain, if they have things like fibromyalgia, or if diabetic neuropathies, or if they have multiple sclerosis, things like that, we will frequently give them medications that are traditionally used to treat other things like seizures or things like depression, and it will actually help to, one, if they have any of those conditions, to treat that, but also helps with neuropathic pain. So this is a common thing we may give, like amitriptyline or carbamazepine. Both of those will kind of help with that neuropathic pain and can make your other agents work better, right? Because ideally you don't want your patients to be taking opioids forever chronically, because that's where you see more of that physical dependence and addiction is the risk goes up there. So these are good agents to try out in order to get patients off their opioids, but we'll talk about these later in a different chapter. So when you're using analgesics in both the children and the elderly, always use it with caution. Be very careful in looking at other medications they may be taking. Typically, the elderly patients have a lot of other drugs they're taking at any given time that may interact. With children, be careful with the dose, because you may not. You want to make sure you're not giving inappropriate dose based on their weight and their age. Okay. Don't give kids aspirin, especially with the viral infections. If they have the chicken pox or influenza, because this could cause that fatal Ray's syndrome potentially, so be aware of that. And then elderly patients are definitely more prone to GI problems like gastric irritation and constipation, so you want to be really careful with those patients as well. One other thing to note is they have any long-acting formulations, don't crush or chew them, because that can actually break that formulation and cause all the drug to be released at one time. So another thing just to kind of keep in mind. So that's it for the analgesic section. If you have any questions, let me know, and I'll talk to you later. Thanks a lot.